introduce the last speaker, Dr. Vishal Gupta, who is now the Chief of Surgical Gastroenterology at the All India Institute of Medical Sciences in Bhopal after serving.
Wow, Vishal, congratulations.
He was at the King George's Medical College.
Yeah, of course.
Long time, but for the last, I think, 2 years, Vishal, you are.
Good evening, sir. Good evening, sir. And thank you. I joined in 2021, sir, July. So it's almost more than 2 years, sir.
Okay.
Please start.
So I think many points have been covered. And first of all, I would like to thank the moderator chairperson to allow me to change my slot. And I would be the last speaker. And I think some of the points have already been covered, but I will just summarize them. And it is a kind of overview of the risk factors and what is the current evidence, what are the newer technologies, and what are the current concept with regards to these anastomotic leak risk factors. So in this presentation, I will not be covering the biliary and the pancreatic anastomosis. It is mainly related to the luminal one. So we know that the ideal anastomosis in GI surgery means there should be no leak, no stricture, and it should function well. But this is not the reality because no anastomosis and the surgeon is 100% immune to the leak. And once leaks happens, it leads to many problems. Multiple interventions may be required. Hospital stay gets prolonged. Financial burden increases, it may lead to mortality, and once patient survives of this complication, there may be adverse long-term outcomes, especially the oncological outcomes. So this is just the incidence of anastomotic leak. Depending on the anastomotic site, it may be 5 to 21% in the esophagus. In the colorectal, it is up to 20%. And in the colorectal, as we go distally towards the pelvic floor, the incidence increases. From 1 to 2% in the small bowel to up to 20% with the colorectal or coloanal anastomosis. So it is expected that esophagus and the rectum, they don't have any serosa. The expected leak rates, they are higher with the anastomosis involved in these organs. So broadly, we can classify the risk factor into different categories. So you can have preoperative, intraoperative, and postoperative risk factor. You can have surgeon-related and patient-related risk factors, and then you can have modifiable or non-modifiable risk factors. So we will go one by one. So we can have preoperative, non-modifiable or non-adjustable risk factors. So these are the risk factors which increase the risk of anastomotic leak. Before I go through this risk factor, if you go through the literature, most of the literature or studies, they are on the colorectal anastomosis or the esophageal anastomosis, very few are involving the small bowel. So the male sex has been one of the important risk factor, higher ASA grade. Then we have comorbid condition like diabetes, pulmonary diseases, vascular diseases, renal diseases, all affect the vascularity. Then ex-smoker. So even if patient has stopped smoking, the risk persists even up to 10 years. Then history of radiotherapy in the form of radiation enteritis, so patient with CS cervix getting radiation in the previous few years, suffering from radiation enteritis might be at increased risk. Then you can have emergency surgery because bowel is dilated, edematous, there may be sepsis. Then distal anastomosis, I have already mentioned earlier, the rectum or the cervical anastomosis in case of esophagectomy. Large tumor size, advanced tumor stage, metastatic disease. So these are the all risk factors associated with the increased risk of anastomotic leak. Then we can have some potentially adjustable risk factors. So these are some modifiable risk factor preoperative, like smoking, obesity, not only the just high BMI, it is the visceral obesity which is also involved with the higher risk. Then alcohol consumption, malnutrition, and hypolipidemia. This is a traditional risk factor. Then, as already been mentioned in the last lecture by Dr. Kale, the certain immunosuppressant drugs or antigenic medicines like bevacizumab, they are all involved with the high risk of anastomotic leak. But these are the adjustable risk factors. Like for this bevacizumab, it is recommended to stop it at least 4 weeks before the surgery and then continue to restart after 4 weeks to minimize the effect of this drug on the anastomotic healing. Then we can have certain intraoperative risk factors like intraoperative contamination. in case of perforation peritonitis, or when the surgery is prolonged more than 4 hours, patient requires intraoperative inotropic support. There is a higher blood loss. There is a need for multiple transfusion. Actually, the duration of surgery, blood loss, blood transfusion, needs for inotropes, it all indicates that surgery might have been difficult. Procedure is difficult. That's why it is prolonged. Blood loss is high. It needs blood transfusion. So these all factors are interrelated. And in terms of your rectal division, rectal resection like low anterior section, it has been found that requirement of more than one stapler cartridge, it increases the risk of anastomotic healing in the double stapling technique. But we also have certain factors which actually are associated with the decreased risk. So we can have preoperative antibiotics in the form of intraoperative intravenous antibiotic or the selective gut decombination that leads to decreased risk. Then we have stapled anastomosis, especially the ileocolic anastomosis, that has been shown to be associated with the decreased risk compared to hand sewn anastomosis. Then we can have thoracic anastomosis after the esophagectomy, having lower incidence of anastomotic leak compared to cervical anastomosis, and the proximal diversion, they are also associated with the decreased risk compared to no diversion. Then we can have certain risk factor in the post-op period. So patient was stable during the surgery, but patient developed shock in the post-op period because of various other reasons. Then this hypotension and hypoxia, that can also lead to increased risk of anastomotic leak. But certain other factors which we actually think of, like these are going to increase the risk of anastomotic leak. In terms of your current evidence, the literature is either there is inconclusive or there is no strong evidence to support these factors like age. It has been considered like age more than 60 or 75 is associated with the higher risk of leak, but that is not so. The neoadjuvant chemoradiotherapy, especially in CA rectum or esophagus, there is no conclusive evidence to support that this increases the risk of anastomotic leak. Again, with the mechanical bowel preparation, which is not going to increase the risk. Intraoperative hypothermia, theoretically, it seems like it is going to increase the risk. That is not so. Epidural analgesia, initially it was thought it is going to decrease the anastomotic leak by increasing the perfusion at the anastomotic site, but again, there is no concrete evidence. NaCIT, there is some evidence that diclofenac can increase the anastomotic leak if used in the post-op period. Then there have been studies with regards to restricted versus liberal IV fluid replacement in the post-op period. Again, no difference in the leak rate. Low versus high ligation of IMA and LAR, again, no difference. Laparoscopic versus open rectal resection or esophagectomy, again, no difference. Initially, it was thought that omentoplasty can decrease the leak rate by giving additional vascularity to the anastomotic site, but again, by going by the evidence, no difference. And again, abdominal drain is not going to affect the anastomotic leak. Although it was initially thought that with placing the drain, there may be early detection of the anastomotic, but again, there is no effective change. Now, coming to the other aspect of risk factors. Conventionally, we over a period of many decades actually, and based on wisdom of practicing surgeon, initially certain risk factors were defined for the anastomotic leak. And these conventional wisdom-based risk factors are technique, surgical technique, tension of the anastomosis, tissue perfusion or ischemia, and nutritional status. But one by one, we will go through each of these risk factors. What does the current literature mention about this risk factor? So coming to the anastomotic technique, does it really matter? So the technique considered, we always think that technique of the anastomosis plays a critical role in maintaining the anastomotic integrity. But exactly what is the optimal technique? It is still not clear. It has remained elusive and uncertain. That's why we have so many techniques, from suture to technique, suture material, suture format, single versus two layer, then interrupted versus continuous. Then we have stapler mechanical devices and so many other things. But all of them has failed to demonstrate any consistent benefit in terms of lower leak rates, except the stapled anastomosis involving the ileocholic anastomosis after the right colon resection, which shows that stable anastomosis have some advantage over the hand-stone anastomosis. So the anastomotic technique, we have to think it again that it is important, but it is not the sole thing to prevent the anastomotic leak. Then again, tension-free anastomosis, does it actually relieve surgeon's tension? Conventionally, tension-free anastomosis is one of the basic tenets of the safe anastomosis. But exact role of this tension-free anastomosis is not clear. It was claimed that tension plays an important role in the anastomotic leak, but it remains unsubstantiated based on the literature, especially at the individual patient level when the leak actually occurs. There is no definitive animal studies or convincing clinical studies which implicates that tension is an important or very important risk factor. In fact, there is one study in 2008 in which the anastomotic leak rate was not found to be different when the sphenic fracture was mobilized or without mobilized during the high colorectal anastomosis. Conventionally, it is recommended that you should mobilize the sphenic fracture to allow a tension-free colorectal anastomosis, but this study suggests that this is not actually the case. There was no difference in the anastomotic leak rate in this study. So again, going through all these points, we have to rethink that tension-free anastomosis is definitely important, but again, it is not the only thing. Coming to the tissue perfusion on ischemia, I think this has been discussed detailedly in last few lectures. We know that ischemia is a commonly implicated risk factor because hypoxia impairs the collagen synthesis. This leads to impaired collagen reinforcement of the anastomosis during the proliferative phase. And because of this, there is a dehiscence and finally there is a clinical leak. And traditionally, we assess the perfusion intraoperatively by certain subjective methods like pulsation, bleeding, or the color of the bowel at the anastomotic site, but these are subjective and not very reliable. So with the neo technology, we have come to the certain things like ICG fluoroscopy for a better objective assessment, but does it supported by the literature? Again, going to the literature, we have mixed result. It might be beneficial, but all studies have not consistently shown any benefit. Like this FLAG trial in 2020, it shows there is some benefit for the low colorectal anastomosis, but for the high anastomosis, it was not found to be beneficial. Still, we have a 1.3% leak rate versus 4.6%. Another trial, Billard 3 trial in 2021, no benefit in the low anterior section. And this latest trial in 2023, it shows that it may be beneficial in the left rectal section because of the lower leak rate. But you have to understand that even with the ICG use, we still have some leak rate. Like in this FLAG 2020 trial, it was beneficial for the low colorectal anastomosis, but at the same time, the leak rate was 14%. It was not nil. It decreased from 25 to 14%, but still 14% is a significant number despite using the ICG. And the same with the essential 22-23 trial, the leak rate was 7.6% despite using the ICG. So with the colorectal anastomosis, results are mixed. It might be beneficial. Maybe we have some more strong data in future to suggest its routine use, but as of now, it cannot be recommended for the routine use. So the coming to the esophageectomy, again, we have the mixed results. Like this study, this was a systematic review and meta-analysis published in 2022. It shows there is a no benefit. Large number of patients, more than 3,000, and leak rate with the ICG still was 9%. Compared to 9% in other group without using the ICG. So they have concluded that it does not seem to reduce the anastomotic leak rate in patient undergoing minimally invasive esophageectomy with intrathoracic anastomosis. This analysis was focused mainly on the intrathoracic anastomosis. Another meta-analysis published 2 years back that shows that there is some benefit for the cervical anastomosis, but not for the thoracic anastomosis. Again, we need to understand that even with the ICG, leak occurred in nearly 5% of the patient. So it is not something that if you use it, there will be no leak. So now we have to think of certain factors beyond the conventional factor. And now the role of intestinal microbiome is re-emerging in general and also for the anastomotic leak. And we know that intestinal microbiomes, there are trillions of organisms within the GI tract. And this host microbiome interaction plays an important critical role in maintaining the intestinal homeostasis. And this concept of effect of our bacteria in the gut on the anastomosis is actually not new. In 1956, there was some animal experiment in dogs when the anastomotic leak rate decreased to near zero when the antibiotic was injected in the anastomotic site. And the leak rate was 80% without antibiotic. And mind you, in both the groups, the anastomotic site was devascularized. So even with the devascularization with antibiotic injected in the anastomotic site, leak rate was zero. And there is a recent reemergence in this area, and there are few studies in humans when they actually analyze the microbiome on the resected mucus in the donut after the rectal resection, and they found that in patients with leak, there is a high abundance of certain bacterial strain like Bacteroideaceae and Lactobacillus. So it is assumed that certain bacteria with collagenase producing strain, they can colonize the anastomotic site and they can play some role in increasing the risk of leak. But still, we don't have sufficient evidence to suggest their role so that we can have some mitigating certain thing to address this intestinal microbiome to reduce the anastomotic leak rate. So just to summarize, the anastomotic leak is still they are an enigma for the surgeon. Usually they are multifactorial, and it is very difficult to predict with high accuracy which anastomosis will fail. And once that happens, it is very difficult to pinpoint what actually went wrong. And we need to understand that problem of leak is actually related more to the biology than to the physics. And as a surgeon, we remain focused more on the physics. But once anastomotic leak happens, our focus immediately shift to the biology of the patient. We think that there is something happens with the patient. There are certain patient-related factors that play a role in anastomotic heal rather than our technique. So with this thing, I will just conclude my presentation. Thank you.
Thank you, Vishal. Concluding remarks from Dr. Supe and Dr. Sitaram, please.
I think, can you just share your presentation, Vishal?
Sure, sir.
Thank you, Vishal, for bringing out many points, a few points which were not really brought. Something like clarity about the ICG and its limitations, which is going on in the literature. I think you brought it very well. As well as the another point you also brought about the newer thinking about microbiota and other things, how they are going to affect. So actually, these are the two areas which are still we are thinking about it. And in spite of all the technologically advantages which we have with the new kind of imaging energy sources and staplers, the leak rates have gone down, but they have not gone completely zero. I think this is what is the final thing we should all remember, is that it is the, as you rightly said in the last slide, it's not only physics, but it's the functioning biology which is very important. So I think everything matters, the way you do pre-operatively rehabilitation of these patients, the way you take decisions on the table, the way you use all these techniques, and post-operatively how you are alert to find out a leak. I think all that really matters. I think I'm really happy to have all the 4 presentations really brought out very important points. And I'm sure all listeners will be very happy with this. I think over to Sitaram.
Vishal, I thoroughly enjoyed your presentation because you challenged many of my pet beliefs in this topic. I would love to have a conversation with you on this topic. It was really very good listening to you. Thank you very much.
Thank you, sir.
Any other faculty colleagues present would like to make any comment before we close? Okay, so if no, then I would like to thank all the 4 speakers and Dr. Sitaram and Dr. Shastri, you are there. Would you like to say something? Thank you, Dr. Sitaram, Dr. Supe. Thank you, Avinash and Himanshi and the Dwarika Hospital team. Thank you very much.